Hi, my name is Michael Rogers. I'm an ICU nurse in Oregon and recently had the opportunity to do clinical work for my undergraduate degree in a hospital ICU setting. For patient confidentiality purposes, I will not reference the hospital's actual name, but instead call it County Hospital. In communicating with the charge nurse at this facility, we agreed that a topic of great concern for community hospital is ICU delirium, which has become more prevalent as patients with COVID-19 are occupying more than half the ICU beds in this hospital. County Hospital is located in Gresham, Oregon, about 30 minutes outside of Portland, serving a portion of Multnomah County, which includes Gresham, Troutdale, Fairview, Corbett, and Wood Village. The hospital serves about 115,000 residents as of 2017, which is close to 20% of Oregon's population. This facility is locally owned by a nonprofit organization and is part of a network of over 100 primary, urgent, and specialty care clinics, a research institute, laboratories, and 7 hospitals. This full-service community hospital was first established in 1922 and is currently ranked as the top-performing hospital in Oregon on key quality and safety performance issues. This is also the first and only hospital that has received all 11 quality performance measures in Oregon's Hospital Quality Incentive Program, showing the hospital's dedication, strong leadership, and ability to improve processes, strive for change, and apply best practices that result in optimum care of patients. This facility is known for being a top performer in preventive health care associated with infections and medication safety communications. In 2020, Community Hospital Center received the Stroke Gold Plus Quality Achievement Award and the Pulmonary Care Excellence Award for superior clinic outcomes in testing COPD and pneumonia. The vision at Community Hospital is to be essential to the health of the region, and their mission is good health for our people, our communities, our world. The hospital fulfills its commitment to the community through its partnerships and community investment and formally participates in the development of a community health needs assessment as part of the Healthy Columbia Willamette Collaborative. The hospital is governed by a volunteer board of directors, a group of healthcare providers, hospital administrators, business and civic leaders, and leaders from the Lutheran and Episcopal churches. They work together to pinpoint 3 priority areas that could have the most significant impact on which were determined to be access to care, behavioral health, and the social determinants of health. Through online surveys, listening sessions, and inventory of community engagement projects, the HCWC heard directly from community members about what they see as priority health issues or problems and what contributes to these problems. The top 5 issues that the community identified are listed in the slide in the blue box. When all this data from the various assessment approaches was compiled, some specific health issues were identified in more than one assessment component, and some common themes emerged as the priority health issues facing the community, which are summarized on this slide in the pink box. The hospital strives to address these needs, the needs for policy, system, and services, and environments to support health behaviors, which means finding solutions for such issues as homelessness, affordable housing, food scarcity, and access to health care. The hospital identified 3 keys to improving the health of the community: education, meaningful employment, and removing barriers to cultural competent services. To help address these issues, the hospital focuses on community benefit resources such as goods, services, and funds to the benefit of the health community, particularly health services for low-income and uninsured. In 2017 alone, the hospital contributed $383.1 million to its health community. Specific initiatives the hospital has undertaken can be found on their online community health improvements plan. The CHNA for Multnomah County reveals numerous external factors that influence the health of the community. Listed on this slide are some of these social determinants of health. Many cities and small towns in eastern Multnomah County and large portions of Clackamas County depend on community health or community hospital, as it is the only full-service hospital nearby. Smaller towns have limited employment opportunities and housing prices that are slowly climbing every year. Oregon is rated as number 13 on the 15 most expensive states to live or one of the 15 most expensive states in the United States. The high cost of housing, food, and the fact that many residents in small towns must drive at least an hour for employment opportunities creates many financial hardships for the community. The U.S. Department of Housing and Urban Development rated Oregon as one of the top states that have unsheltered homeless populations. There's a huge problem with our state in providing patients with adequate and timely mental health. In fact, Oregon ranks as one of the worst U.S. states for mental health, ranking 49 out of 51. Combine with this factor the high prices of food, transportation, and housing, and you'll have a recipe for disaster. 70.8% of residents have no religious affiliation, which may further limit community members' access to supportive community. Church services offer the congregation time to meditate, reflect, self-reflect, and serve, although these opportunities can be found outside of a church building and without religious affiliation. Multnomah County, compared to its three closest counties, had the lowest median household income in the four-county region, and about 19% of the population is living in poverty, with 26% receiving Medicaid. 91% of the residents have at least a high school diploma, and 41.6% have at least a four-year college degree. By ethnicity and race, the hospital's primary services is 73.6% non-Hispanic white, 15.7% Hispanic, 2.1% African American, 4.4% Asian and Pacific Islander, and 3.6% multiracial, 0.1% other race, and 0.7% Native American. The county has a 751-to-1 ratio of population to primary care provider and a 159-to-1 ratio of population to mental health care provider, making it the highest population to health care provider ratios amongst the four counties. At the beginning of 2020, the world was rocked with a new coronavirus called SARS-CoV-2, which causes COVID-19. The virus was first discovered in Wuhan, China, and at the end of 2019, and its ability to spread rapidly and seemingly unpredictable nature of the virus, its lethality, its novelty, caught everyone by surprise and quickly spread through the world. The virus has impact on all aspects of life and rapidly changed the direction and focus of individual communities, leaders, scientists, healthcare, and economy, and politics worldwide. Coronaviruses are a large family of viruses that are common in people and many different species of animals. The SARS-CoV-2 virus is a beta coronavirus, and these viruses have their origin in bats. The virus causes respiratory illnesses which can be spread from person to person through respiratory droplets. Data suggests that there can even be transmission of COVID-19 through droplets of those with mild symptoms and those who do not feel ill. Short-range transmission is plausible in crowded areas and in inadequate ventilated spaces. There are several aerosol-generating procedures in hospitals, which are listed in this slide in the yellow box. Most COVID-19 illnesses are mild, and most patients will recover, especially children and young adults. Data from several countries suggest that 14 to 19% are hospitalized, and 3 to 5 will need intensive care admission. In some cases, people become seriously ill and develop difficulty breathing. The CDC states that these severe complications can lead to death. The risk of severe disease increases steadily as people age. Additionally, those of all ages with underlying medical conditions, including but not limited to heart disease, diabetes, and lung disease, appear to be at higher risk in developing severe COVID-19 symptoms compared to those without these conditions. As of September 26, 2020, the USA has over 7 million total cases, with 303,000 cases reported in the last week. Of the 7 million plus cases in the United States, there have been 180 deaths. The U.S. accounts for about 25% of cases and 22% of deaths in the world, only about 4% of these world's population. Oregon has a low rate of COVID-19 cases compared to the rest of the nation, but on September 26, 2020, OHA reported 457 new COVID cases, the highest number confirmed in one day. Oregon has reported a total of 32,314 cases statewide. Positivity rates have been steadily declining since August, but during the week of September 25th, there has been a surge in new cases in counties all over Oregon, especially Multnomah County, where 26 cases came from, making the county the top contributor to the 457 daily cases. The OHA director cited numerous factors contributing to the increase: social gatherings, students returning to college campuses, wildfires impacting testing, and people seeking treatment for respiratory problems. According to the CDC, as of September 26, 2020, there have been 542 reported and confirmed deaths from COVID in Oregon since January 21st of 2020, with a total number of confirmed cases of 32,314. About half of all COVID-19 deaths in Oregon are linked to living in nursing homes. Data showed that Latinos and African Americans are 3 times more likely to become infected and twice as likely to die as whites. Experts say that this is likely the result of having jobs that don't allow groups to work from home, long-standing disparities in access to healthcare, and living in more crowded or multi-generational households. Hospitals are preparing for a surge of new cases in the fall when the warm weather disappears and Oregonians start spending more time indoors. Hospitals could be overwhelmed as they struggle to treat COVID-19 and influenza patients simultaneously. This slide illustrates a timeline as COVID gained hold in the United States and as it spread through Oregon. This slide shows a continuation of the timeline, most importantly illustrating some of the critical errors, mistakes, falling short of what should have happened, which would have potentially curbed the spread of the COVID-19, both in the United States at a federal level and in Oregon at the gubernatorial level. There are many negative psychological and physical consequences of prolonged ICU care. One major consequence is ICU delirium. Injung Cha and Johnson reported that the virus has a major toll on long-term physical health, with long-term psychological, emotional, and physical consequences for those who receive ICU care. Prolonged ventilator use, which is common amongst COVID-19 patients, experience extreme psychological strain because of prolonged periods of isolation, anxiety stemming from the pandemic, and the emotional stress of trying to fight the virus. According to Sikandar et al., 73.6% of patients admitted to the ICU with COVID-19 experience delirium that persists for approximately 1 week. Invasive mechanical ventilation is significantly associated with odds of delirium. Clinical attention to prevent and manage delirium and reduce delirium duration and severity is urgently needed for patients with COVID-19. Many of the patients I have had that test positive for COVID-19 have experienced symptoms for 5 to 10 days before entering the hospital and come in with emergent circumstances, usually by ambulance. The vast majority of these patients are placed on ventilators for more than 2 weeks. According to HelpEarn, in the U.S., the average length of stay in the ICU is 3.8 days. From what I see, patients with COVID-19 are staying in the hospital much longer than this, increasing their likelihood of experiencing ICU delirium. A systematic review of 52 studies that looked at hospital stay for COVID-19 patients worldwide found that patients' stay varied greatly from less than a week to nearly 2 months. ICU's reported median of 1 to 3 weeks length of stay. On this slide, you'll see 3 weaknesses listed for the local community that's made it difficult to get a stronghold on the COVID-19 virus. Oregon doesn't have the testing capacity it needs, doesn't have the contact tracing, isolation policies for infected people, and facilities to quarantine these infected people into, or even federal testing aid. Mask wearing and social distancing, hand washing, all the things we know that work to prevent the virus's spread have been highly politicized. And conspiracy theories and crooked leadership has led to misinformation and distrust, which causes great social unrest. 3 of the great strengths I see at the community hospital used to combat this ICU delirium as a result of prolonged ventilations and hospital stays is that every day ICU delirium is discussed by a multidisciplinary team in the ICU, addressing whether it's present and what can be done about it. And then throughout the day, the physician and the chargers make a daily effort to check in with the nurses and see that the recommendations are being met to combat delirium, ICU delirium. And the hospital is constantly seeking out evidence-based solutions to fix problems. This is a slide about recommendations. The ICU Liberation Bundle can reduce ICU delirium, help with pain management, and aid in lessening the long-term negative consequences of being in the ICU. To help health professionals to remember the steps to the bundle, one must simply remember their ABCs. The A stands for assess, prevent, and manage pain. Pain can be assessed by following the steps in the A box, as well as non-pharmacological interventions are also suggested. B stands for both spontaneous awakening trials, SAT, and spontaneous breathing trials, SBT. This is the time to stop sedative medications, orient the patient to time and day, and connect an SBT to help the patient to breathe without the use of the ventilator, as prolonged use is shown to reduce survival rates outside of the ICU, and is also known to increase death in the hospital. Prolonged ventilator use also increases the length of stay in the ICU and physiological stress and ICU delirium. C stands for choice of analgesia and sedation. The ICU team should daily evaluate the need for continuing pharmacological interventions for pain or agitation. The C box gives tools and scales to use for checking agitation, depth of sedation, delirium, and appropriateness of sedation. This slide is a continuation of recommendations. D stands for delirium, specifically assessing, preventing, and managing delirium. ICU delirium increases the risk of death and can cause long-term cognitive impairment. E stands for early mobility and exercise. It is important to have a strategy on how to implement early mobilization, but before starting the process, think about the aspects found in E box of the slide. F stands for family engagement and empowerment. Patient-centered care is defined as providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring the patient values guide all clinical decisions. Empowering family members with shared decision-making, safety, and future care expectations engages them in the patient's care. These are the references that were used throughout the PowerPoint presentation. And this is a slide that continues the references that were used throughout the presentation. Thank you for the pleasure of your time.